All right, good morning. I want to welcome you all to my office and have coffee with me this morning. Thank you. And take off your masks, and you can meet my puppy, who's Spinoza, who's a philosopher and a Spinone. And he's going to help me out a little bit this morning. And this is great because you get to join me in my office. Um, just a little bit about how we're going to start this morning. We're going to be talking a little bit conceptually about how to think about eating disorder treatment, and then lay out the goals and targets of treatment. And then the last hour, there'll be a 2-hour workshop, really is going to be oriented towards tools for clinicians. So my goal when we're done is that, literally you'll be more effective in what you do in your office starting tomorrow. And a little bit about us. Those of you who are back, I appreciate your coming again. And those of you who are new, Harmony Place is a partial hospitalization program. And we have a beautiful house that people can live in from out of town and have a therapeutic community where 8 people support each other, help each other with meals and such, and then come in for 6 hours a day. And typically people coming in are here for, maybe a 2 to 3 month length of stay. And they have 4 individual sessions a week, and it's very intensive therapy. We tend to deal with deeper issues. And it's, of all my incarnations, I've had inpatient, hospitalization, so on. This has been the most effective mode of intervention. Okay, I'm going to go ahead and start now. Those of you who have hard copies of the slides, you can follow. And let's see. The first one is just simply a couple of references that, if you're going to read one thing, read Shafet's book. It's really good. And Kathy Steele's book. Those 2 books have changed the whole field and are wonderful. And Subert's book is the first one applying this to eating disorders. And then Bromberg is this area of what is the development of the self. And he has a number of books that are quite profound in this area. All right. So I'm going to just say that, I guess I've been sort of a rebel in the eating disorder field because I've been preaching for 30 years now that we need to take a trauma-based approach to working with eating disorders. And I'm reminded of Fairbairn's 2005 quote that there's a pressing need to develop more effective treatment for adults, particularly with anorexia, because our outcomes are poor. And to me, I think we needed a new conceptual frame. Cognitive behavioral therapy is necessary, but rarely sufficient. Family therapy is necessary, but rarely sufficient. And so I'm going to offer today what I've evolved as more of a dissociative approach to looking at eating disorders. To me, it's obvious that eating disorder is a dissociative disorder and it had us with a somatic basis because, typically when a person looks in the mirror and the image that they see is not them, it's a disorder of self. And we need to go back to object relations and such and begin to work at from a dissociative perspective. So the field of dissociative disorder is really highly evolved with these new books that I've pressed to you. So just to remind you that the data from Strober that the long-term course of severe anorexia means very few successes, and that it takes years to treat an eating disorder, and the longer you get, the more success. But I struggle with these data because I don't think that the way we measure success is sufficient. I think that looking at eating as a criteria for success is necessary but not sufficient because in my clinic, I also treat chemical dependency and other addictions. And what I see is people who had eating disorders when they were 13 to 16 years old, now coming in their 20s and 30s with suicidal depression and alcohol and chemical abuse. And so I do think we need a broader perspective in thinking about evaluating success. And so I just say here that it's not just the absence of symptoms. And what Marsha Linehan said, we need to help a person create a life worth living. I remember my first eating disorder client, I did this incredibly good work, and we got her back to recovered weight. It was healthy. We did a lot of work with the family, and it felt like a great success. And she said to me, Mark, I don't know how to live in the world. And I said, what do you mean? Like, what don't you know how to do? And she said, well, I can't pay my bills. I can't interact with people. I don't know how to live in the world. I said, well, I can teach you how to pay your bills. And she said, Mark, you don't get it, and I don't think you ever will. And I listened to her because I didn't get it. And what I didn't get was that it was far more, the food represents something much broader, which is, that whole area, particularly for the anorexic, of launching and knowing how to live in the world. And in her case, she lived in an enmeshed family where her mother did everything for her. And so she never individuated and never developed a core sense of self. And so I realized that what I had done was necessary but not sufficient. When I went to follow up on her 3 weeks later, she was living in a room with cans of beer all over the floor and utter clutter, and she hadn't left the room for weeks. And I think it would have been a treatment success if we would have measured eating disorder, but clearly it was a treatment failure. So I decided to go back to the drawing board and be able to rethink how I work with eating disorder clients. And this quote really helped me because it says the questions which access to is adequate is somewhat problematic, and that the clients with eating disorder tend to have highly perfectionistic areas, and they have personality pathology. They have patterns of thought, feeling, motivation. They're self-critical, perfectionistic, competitive, and these are all personality disorders, but they're not really included in Axis 2. And so Axis 2 really is insufficient in being able to look at the personality disorders, particularly of our eating disorder clients. And so it's almost like we have to change the diagnostic category to look at this area of personality. And so, to me, perfectionism is basically self-hatred by another name. And we have to ask ourselves, how does one reverse the perfectionistic self-critical aspect of this? I think for most of us, we realize that this is an obsessive compulsive disorder, and that it's, in many cases, it looks a little bit like OCP, obsessive compulsive personality. And, that literature on that is legendary in terms of the difficulty of treating OCPD. And so if you have obsessive compulsive personality disorder characteristics, or even autism spectrum kinds of things, what are we doing to treat those comorbid kinds of personality issues? And that's really partly what I'm going to be addressing today, is the problem behind the problem. So the way I think about it is a client comes in with symptoms. They have chemical dependency, they have eating disorder, they have depression, and they think that's the problem, but that's the symptom. And that what we must do is ask ourselves, what is the problem that's underneath the symptom? And treat the problem underneath the symptom. And that's where conceptualization of the case becomes important. So you can see why I'm spending this time, because I think in many ways, what we're doing is necessary but not sufficient. My model of treatment is that if you're treating an eating disorder, it's not one syndrome. That take anorexia. there are probably 10 really predictable trajectories for anorexia. You know, what I did is I studied the cases that we had, and I outlined different trajectories, and I found that they were mutually exclusive and exhaustive. In other words, there were about 10 different trajectories. And the way you treat anorexia is not like this is how we treat anorexia. You have to treat anorexia by understanding the trajectory. By trajectory, what I mean is the developmental pathway for individual patients. And that usually it comes on as a survival strategy during childhood and adolescence, where a person's trying to develop a sense of self. So one trajectory is you have an enmeshed family where the individual doesn't have a sense of self and doesn't have any control. And so the parent is very over-controlling and Phi Beta Kappa parent. And so what happens is that the child doesn't learn the adequate stresses at different stages of development and doesn't have the freedom to go out and develop mastery. And so the individuation process is interfered with. And that subtype of anorexia is very different to treat than one who, you know, from a very young age has an attachment disorder and is unable to be held and touched and picked up and has eating problems right from birth. That's a different trajectory. And then that's very different than one who's incested. And so what one wants to do is identify the trajectory of the eating disorder. So anything I say related to an eating disorder is only true for a certain subset of clients, not all of them. And it's important to remember that. And so our model is a developmental model. And in that developmental model, what we assume is you've got to know the contributing factors in order to be able to treat it. And the treatment is highly dependent upon the contributing factors. So for example, some eating disorder clients require family therapy, some don't. Some need trauma therapy, some don't. And some respond better to cognitive behavioral and some don't. And that's a really critical aspect. Now, again, in a conceptual frame, I've always loved David Kaloff's statement about looking at trauma, because the first 100 clients that we had at my old facility, which was Castlewood in St. Louis, I gave the adult attachment interview to. And in that group, what we found was that 100% of the first 100 clients that we saw had disorganized attachment. And that turned out to be a really important finding. And so if they have disorganized attachment, my hypothesis was that the ones who got better were the ones who we treated the disorganized attachment rather than the eating disorder. And so I had to begin to conceptualize how you treat disorganized attachment. And so what I want to do is say to you that disorganized attachment, according to Schwartz and his colleagues, if you follow them up from birth onward, the most common adult disorder is going to be dissociative disorder. And so disorganized attachment and dissociative disorder need to be the target diagnoses that we're looking with eating disorder clients. So let me just repeat that because it's critical to what we're saying. That the first 100 clients that we treated, we gave the adult attachment interview to, and 100% of them had disorganized attachment. So I decided that we needed to treat the disorganized attachment rather than just the eating disorder. And therefore, I had to conceptualize how you treat disorganized attachment. And what goes with disorganized attachment is a disorder of self, and what goes with disorganized attachment is dissociative disorder. And so the reason why this workshop is important is very little has been written on the dissociative features of eating disorder, except for van der Linden over in Denmark and people like that who've been preaching this for years. Now, the eating disorder then is a container for the unmetabolized trauma. And so as we began to go from PTSD trauma to complex trauma and look at the critical life events, what became important is to understand what is trauma and what is trauma for an eating disorder client. Those are the questions that we're going to be asking today. Now, the third part of this is that eating disorder symptoms are always translogical. So, for example, translogical means that if you could get to the mind of the 3-year-old or the 5-year-old or the 7-year-old and look at what they're able to perceive at that time, what you'll find is that obviously the way a child thinks is different than an adult thinks. And so, if you're watching your mother have an affair and you know about it and you're actually watching her have sex with a stranger, how does a 7-year-old's brain take something like that in? Not like an adult. So we have to go back and look at the way the 7-year-old primary process thinking took that in and encoded it in their brain. And so somehow the symptom makes sense within the primary process thinking of the 7-year-old. And a lot of the cognitive-based therapies have to be able to look at the primary process thinking. So we have to access the injured self and bring the injured self, which is the 7-year-old, in the room. And so, what I realized over the years was that, I needed to become a child therapist, not an adult therapist, because so much of what was happening with my clients happened in childhood and had never been addressed. And so we had to figure out how to be able to work with the child parts of the adult. So, when you say we do inner child work, that always seemed like such a cliche until I recognized that the injury was to the 7-year-old or the 10-year-old or the 13-year-old, and I had to work with that part separately than the adult. The adult self usually knew what I knew. It was the injured parts of self that had been dissociated and locked out, and the symptoms were generating from the injured parts of self. I hope that's clear to you all. It's a really important conceptual frame. Okay, so one last sort of conceptual point, which is that running an eating disorder clinic, it was clear to me that I needed to have specialists in different areas. And so if I had a weak dietitian, my treatment oftentimes failed. If I had a weak psychiatrist who didn't know eating disorders, my treatment usually failed. And so every piece of the pie had to have an A-level person if we're going to have A-level treatment. And so you have to have incredibly good family therapists. You have to have a behavior therapist. You need to have some form of affect work where you're working with psychodrama or other forms of affect facilitation. We had to work with the partners, the co-addicts, the enablers. We had to work with medication. We had to work with response prevention and have a setting where we could, like an inpatient or partial hospitalization, where we could get under control through that relapse prevention. We had to deal with the complex or PTSD. We had to make sure that we were moderating their meals, and we had to deal with body dysmorphia, sexuality, and femininity for the women and masculinity for the men. So you see what I'm saying is that if any one of these components is weak, your whole program was weak. And the hardest thing was being able to get A-level people in each of these categories. And also, if you're an outpatient therapist, it's so hard because you can't be good at all these things. And therefore, you have to have a team of people that you work with, that you trust, and any one link in the team that is less skilled obviously becomes problematic. All right, so the first statement then is that an eating disorder is functional. And so I just began to categorize, what are some of the functions of eating disorder clients? Well, the important of this is that there's usually about 10 functions of an eating disorder for a client. And so the client that I'm seeing now is sort of, when she originally developed the eating disorder, it was her only way of having some sense of control in her life. Her parents were incredibly over-involved. And when she came in and she said, I don't belong here. I haven't had any trauma. I had really good parents who did incredible things. And what she didn't realize was that being kept from individuating is trauma. And what happened was that the parents made all the decisions for her. And now that she's a young adult, she's terrified to be in the world. And so she went from being like this to being like this. And she felt like thrown out of an airplane without a parachute. And so she tried to kill herself. And but now the problem is not having some sense of control, but for her, it morphed. And now it's a way of getting attention. It's a way of getting love. It's a way of getting cared for. And so now it has a new function in some ways. It's a way of keeping her from developing a sense of who she is and knowing that she doesn't have the structural capacities to live as an adult. She doesn't know how to socialize with people. She doesn't know how to be on her own. And so what I've incorporated into our treatment model is life coaching, because I found that there was a limit to what we were doing in our office, and that sometimes I'd go to their homes. I couldn't, obviously, but a life coach would go to their homes and find out that the way they were living was, they weren't telling me, but was incredibly dysfunctional. And so, let me give you an example. Life coach would take the client out to, we have these little markets on the street here in Monterey. And when she would go out, she'd be bent over like this, looking at the ground, her eyes looking down like this, being able to say, I'm approachable. And so she would have the person straighten up their body and begin to look at people and smile and begin to start conversations with people in the market. And that intervention in and of itself structurally changed an enormous number of things. But I would never have seen that had I not had a life coach be able to do that. So I hope you're getting my point, which is that I want them to be able to have a life. And so in order to be able to have a life, I have to be able to assess and treat some of the problems behind the problem. And so you have to understand the function of the symptoms. And the basic function of the symptom is I'm alone. All I have is my eating disorder. Now, in my naive younger days, I thought, well, if I just teach them social skills and get them talking to people and help them date, that would be sufficient. And what I didn't realize in that stage of my thinking was that they really don't have a receptor for connection. And so there's a concept called receiving love. And love can be out there, but if you don't have a receptor to connect to other people, then you feel like an object, you've been treated like an object, and you're so numb that your primary relationship is with your eating disorder, and your secondary relationship is with people. And so if you don't trust people, if you can't feel safe with people, you obviously need your eating disorder. And so the client would say, don't take my eating disorder away. I can't live without it. I love my eating disorder. And it almost sounded like an erotic, romantic kind of relationship. They were infatuated with their eating disorder self, and they required that in order to be able to exist. And so if you understand that this is a disorder of attachment and they can't connect, then the essential symptom of eating disorder is loneliness. It's them and their eating disorder, and everything else is sort of secondary. And the cure has to be understanding it as an intimacy disorder and opening up. It's sort of like, if you want a metaphor, sometimes you'll have a hormone in the body, but the receptor for the hormone is impaired. So even though you're measuring the hormone, it looks like a normal level, it isn't functional because it isn't binding with the receptor. And so you have to treat the receptor rather than the hormone. Well, in a similar way, you may have a lot of love. You can have a husband or a wife who's very loving, but the person can't receive love, and it gets pushed back, and the person will say, I hate myself, I feel like I'm defective, and be shame-bound. And you want to treat the shame, but even the shame is a subset of the disorder of intimacy. Okay. So I hope you're buying what I'm saying, which is that, so an eating disorder is primarily a disorder of intimacy and attachment. And so you're now going to ask the question, well, okay, I buy that. Treating the eating disorder is necessary but not sufficient. And we will treat the food-related behavior, and all that work that we've learned over the years is necessary but not sufficient. How do you treat the attachment disorder or the intimacy disorder? All right, let's address that for a little bit. So I'm very fond of this book called Becoming Attached by Robert Caron. It's a nice book. I give it to the clients to read, and it's very, very user-friendly. And what he shows is that the anxiously attached children, that is the children whose were oftentimes neglected, and the subtype of individual who was parents were busy at work and didn't give the child what the child required in order to thrive, which Mary Main thinks is about 30% of parenting is sufficient. So there was less than 30%. And so the child is deprived of love or is actively abused. And in the young children who had anxious attachment, they had a hard time tolerating any frustration, the parents would. And so the parents would get in there and solve the problem for the child. And that interfered with the child's individuation. And so oftentimes what you see, particularly with anorexia, is a parent who is over-involved and is over-controlling, but yet absent, which is a toxic mixture. And the other thing that Robert Caron talked about is that the parent showed roughshod over the child's interest in certain ways. I used to run an attachment clinic for kids, and I would bring the parent in with the child. And it was so fascinating because we would have play in there, and the child would pick up a toy and play, and the parent would sort of take the toy away from the child and give the child a different thing to play with. And the child would throw it away, and the parent would come in and give the child a different thing to play with. And it was sort of like the parent wanted the child to do what the parent wanted the child to do, and was over-controlling. And oftentimes, these same parents had marital problems, and they were over-controlling in their marital relationship. And they would run roughshod of the natural rhythms of the child. So, you know, the question is like, is an attachment problem where you don't hold your child enough, or that you don't have physical contact? Well, yeah, but it's more and more the data is showing it's picking up the child when the child wants to be picked up. And so you have these excitatory pathways and inhibitory pathways. And so when the child is overactive, then what they need is soothed and calmed. And when a child is really numb and sort of laying back, what you need is to, boo-boo, excite them in some ways. And so those pathways differentiate by the attunement of the child with the caretaker. And there, more and more, from the mirror neurons, that the child's central nervous system seems to be electronically connected to the parent. And so it's that attunement that has been talked about that is important. Now, obviously, the client is not going to report to you the misattunement. And in complex trauma, probably the root of it is in misattunement between the child's natural rhythms. And so all children are born with dispositions, and the parent needs to be able to work with one child different than a different child by being able to attune themselves to it. So in childhood attachment clinics, there's more and more of an emphasis on understanding the natural rhythm of the child and teaching the parents to be able to be attuned to them. Now, that really is important because so much of repairing the attachment is learning as a therapist to attune yourself to the client's style. And so in disorganized attachment, you have a mixture of avoidant and with anxious attachment. So you have a part of self that desperately wants you to hold them, love them, and care about them. And you have another part of self who's highly avoidant, who hates and distrusts other people and wants you to stay away. And so that then interacts with the transference and countertransference. And so, let's say the client says to you something like, oh, you're going on vacation. Obviously, you don't care about me. Well, that's a classic example in boundary issues, and how you handle it is really sensitive. But how you handle it if you have disorganized attachment needs to be thought out quite differently, because there's one part of self that's saying, do you love me? Another part of self that's saying, I told you, that this person's going to reject you like everybody else. And therefore, how you process it depends on which part is. And in disorganized attachment, there are both avoidant and anxious parts. And therefore, how you deal with it with one part is going to be different than how you deal with it in another part. Okay? So these simple rules that you use of how you deal with transference and countertransference or boundaries really are much more complex with the clients that have disorganized attachment. Now, I'll try to get to how you actually deal with that, but I want to just lay out the frame. All right, so we're talking about misattunements, and if you're misattuned, then obviously the child feels like they're bad. Any child will feel like they're bad or feel shame if they feel rejected by a parent. And so most of the damage to children are done unconsciously by parents. They don't even know they're doing it, and the kids are unconscious of it being done. And so they're not going to be able to report it to you in your history. And so you have to assume that if they have an eating disorder, there's something in the family environment that contributed to it. And you want to begin to unfold that. Now, you have to be careful, because I'm not talking about bad parents here. Or, every parent comes in feeling like if the child has a mental illness, that they're at fault and blame. And I don't buy the fault and blame piece of it. I just think that it's the certain needs of children need to be attuned to the certain needs of adults. And sometimes there's a misattunement in some way, and that lead to great difficulties. Okay, so moving beyond this now, I want to talk then, if disorganized attachment is at the root of eating disorder, and adult clients with disorganized attachment demonstrate dissociation, the question then is, how does dissociation play a role with eating disorder clients? And first, I want to just say that, if you use various measures of dissociation, there's a high correlation of dissociation with anorexia. I think sometimes the way we measure this has been difficult. The DES was the original Putnam measure. Then there came the DES2, which is a little bit better. And then Colin Ross came up with the DDIS, which is even more useful. And then came the SCID-D, which is most useful. And each of them you're going to measure differently. But if you use the SCID-D, which is the gold standard, you'll find that eating disorder clients have high dissociation. And that the food is not simply a symptom to be getting rid of, but it holds dissociative parts of the patient's self and history. So this is a quote taken from the book by Chavez. And I love this quote, so I'm going to read it to you and then I'm going to interpret to you. It says, food is the most significant relationship in the eating disorder individual's life. The symptoms have lost connection to the problems, vulnerabilities that stimulated their onset and have taken a life of their own. They're now ingrained habits with their own rhythms and expression. It becomes a valued friend, a secret companion. This lessens anxiety becomes a strict taskmaster or abusive tyrant that punishes transgressions. Now, what I mean by that is that one when a person has a dissociative disorder, sometimes they'll have imaginary playmates. An imaginary playmate then sometimes continues to exist and becomes part of the eating disorder self. And so this self, is sort of like either a tyrant that comes in a persecutory way and says you must work harder all the time in order to be loved. And so the disorder of self is that they become a highly reactive individual who is trying to meet the needs of others. And so they live in constant anxiety and fear of rejection. And the anxious attached part is, if I work harder, if I do 100%, if I'm highly perfect. So no matter what they do, it's not enough. And the eating disorder is like a tyrant that drives them in certain ways. On the other hand, the eating disorder can be a valued friend. When you're lonely, you turn to your eating disorder and it numbs out your feelings. And so you don't feel so lonely anymore. And so it then morphs and becomes your best friend. And what you know is that when you're alone and feeling really lonely and depressed and want to kill yourself, you turn to your eating disorder. So if you come in and naively and you say, oh, I'm an eating disorder therapist and I'm going to take away your eating disorder, and I'm really good at taking away your eating disorder, the person is going to say, no, don't take it away. So you have this paradox where the client is coming in and hiring you in order to be able to help them eat, while at the same time is 100% of their effort is not trusting you because you're taking away their survival strategy. And that's the paradox of working with eating disorder. Usually when a client comes in and says, I'm depressed, they want to get rid of their depression. But the paradox with eating disorder is there's an equal amount of energy to wanting to get rid of the symptom as maintaining it in some way. Okay. All right. So the idea then is that the therapist needs to understand the function of the symptom and the parts of self that have become disconnected and what they hold, and work with these separate parts. Okay, one final piece then is that the part of dissociation that is ubiquitous and that there is repetition of the trauma is reenactment. And reenactment is pathognomonic of trauma. The person is going to repeat over and over again to finish whatever doesn't make sense. Now, let me explain that. When you have disorganized attachment, what makes it disorganized is that what is happening in the person's life doesn't fit into the schema. And so, I love my parents, they're safe. Why are they doing this? So like with one of my clients, he said, my parents are perfect. They go to church every Sunday. They're loving, they're caring. They did nothing but show us attention and love and care. And I then was in group and I had talked with the brother of one of my clients, and the brother said, well, there's one thing that didn't make sense in my family. One time, the client and I were at a department store, and we went around a corner, and my mother was kissing a stranger. And we saw that, and it was really, really confusing. So here we have mother kissing a stranger, having an affair in a God-abiding, good family. And how does one put that into the whole? So what happens is that those events don't fit into the cohesion. And so when there's enough of those events, you begin to get a disorder of self because you can't integrate these pieces of information. So they get thrown out into the associative network. And in these PET scans that sort of look at this, what you see is that the amygdala lights up with state-dependent memory, and the hippocampus is up here, and it can't be integrated into the hippocampus because it's state-dependent memory. Well, that to me is a good model of thinking of disorganized attachment, which is there are pieces of information that don't fit into the whole. And so, what we have to be thinking of is that therapy is always integrating. We're integrating disowned parts of self. We're integrating pieces of information that don't fit into the whole. We're integrating self systems that have been separated, i.e. dissociation. And so there's a part of self that's angry and there's a part of self that's passive. And so when Richard Schwartz came up with internal family systems therapy, he said all parts are polarized. So if you find a part, you'll find a part that's just the opposite. Or Marsha Linehan in her dialectical work is, for everything that's true, the opposite is true. And in disorganized attachment, there's always contradictions. For whatever the person believes, they oftentimes believe the opposite. So there's so much energy put between these disowned parts of self that they're fighting each other. And the energy inside is intrapsychic energy. And these intrapsychic issues keep them from dealing with problems out here. So there's so much anxiety and depression because of the internal distress that they can't really address conflict and problem solving in the outside world because there's so much energy involved with internal. Now, where you see this most beautifully is in dissociative identity disorder. And if you've treated dissociative identity disorder, you'll never treat your other clients the same way because you see these dissociated self systems in extreme form. And what you learn from dissociative identity disorder, you then apply to your non-dissociative identity disorder clients. And it's incredibly useful because you find that there's the same kind of patterns. For example, there's a client that has a persecutory part of self, and you have a client who's an internal self-helper, and then you have an injured part of self. Then you have that triad always with dissociative identity disorder. And you find that that triad exists in most people, that they have these injured parts of self, that you have these helper parts of self, and you have these persecutory parts of self. And now that you know that triad, how you work with that in a client that does not have dissociative identity disorder becomes so much more obvious. So there is reenactment. And that's why, if the client has had sexual abuse, for example, as a child, that there's usually 5, 6, 7 rapes that follow that. And the question is, what happens that make a person vulnerable to these other kinds of traumas in their life and their choices of companions in certain ways? And that is, the reenactments are always within the components of dissociated parts of self. There's a lack of self. Okay, so now I want to enlarge what we're saying. I've said you have eating disorder as the primary symptom. You have underneath that disorganized attachment that needs to be treated. That the manifestation of disorganized attachment is dissociation, which needs to be treated. And the fundamental problem with dissociation is a disorder of self. And so what one has to be able to consider is, how do you see the development of the real self? And so to understand this, I went back to Kohut, Winnicott, Masterson, and that if you go back and reread those basic self-psychology pieces, you begin to understand there is a false self, and the false self is a self that you create in order to not disappoint others. And so in a world where we're filled with, you have to be successful, achieve, and make a lot of money, the false self is highly oriented towards all three of those things. And that the false self blocks the development of the real self. And the real self is the person who internally is able to love, who can feel and can sense. And so all the work that we do under mindfulness and getting back in one's body and somatic basis of therapy, or working in somatic mastery, these early deficits in somatosensory, are all oriented towards helping the individual get back in their body. So Pat Ogden's book, Gianna Fisher's book, and most of the dissociative disorder books are working in being able to help people in a somatic way understand somatic dissociation and understand the person has not only do they have body dysmorphic disorder, but they are unable to incorporate into their bodies a sense of self. And so self-development needs to be a whole separate area. So in the way I think about therapy is that we have to have trauma group, and then we have to have a group oriented towards skills orientation, teaching them how to have life skills. And then we have to have a group around body and somatic and being able to get back into one's body. And so that then defines the definition of an eating disorder program, that these three components are absolutely necessary in the group therapy. And then in the individual therapy, we do a lot of work to be able to allow that to happen. All right. Pathological dissociation, then, just in a definitional way, that you have to distinguish this pathology from normative. And so look at these words: loss of executive control. Well, you don't have control over food, or you're over-controlled with food. That's clearly true with eating disorder. There's a change in self-representation. It's almost like they're 97% eating disorder and 3% self. And so if you're trying to enlarge real self, oftentimes the client comes in and 97% of them is eating disorder self, 3% of them is self. So as you enlarge self-development and differentiation, obviously the eating disorder begins to step back. Amnesic barriers, ownership over behavior. These are what defines pathological dissociation from Kluft, and they're also what defines eating disorder clients. So you see the overrepresentation and why something like this needs to be much more attended to. I want to then say that a lot of therapists reject this. I mean, I've lectured at eating disorder conferences for years, and a lot of this gets to be rejected and even threatening to people. And, there's criticism, like somehow we're making the person less integrated rather than more integrated. And I always like Sakine's idea that, the inability to see these parts of self is kind of transferential in and of itself. Most psychiatrists have not been trained in dissociative disorder, and they don't know the medicine requisites for dissociative disorder. A lot of therapists haven't been trained in dissociative disorder. And so when they come to this, it's not an area that they're skilled in, and therefore they're kind of allergic to it in some ways. I think it's less so because of internal family systems therapy and Gestalt work and more affect-based therapies and somatic oriented therapies. I think people nowadays are less rejecting of this, but since I've been doing this for 40 years, it's been very, very controversial in some circles. And, many therapists say they've never seen a dissociative client, and that's because they're not looking at it through that lens. So just remember that not seeing it is kind of transferential. All right, now, if we're talking about a disorder of self, we probably need to define that. And so I always like this consensus from the DSM. And so I like this piece because it helps me get an assessment diagnosis. A disorder of self is intense preoccupation with safety of the caregiver. And that means that the number one block to changing disorganized attachment is loyalty to the family. And so as soon as you start looking at family influences, the client will immediately wall you off. And so the resistance is almost 100% of the time around loyalty to the family, because anxious attachment means a lot of energy in getting the parent who is unloving to love them. And needing to believe that if only they do X, that they can create love from others. 2 is a persistent negative sense of self, self-loathing, worthlessness. If you're thinking about your typical eating disorder client, you can see all these characteristics. 3, extreme and persistent distrust, lack of of close relationships with adults, the inability to receive love. 4, reactive physical or verbal aggression towards peers or caregivers. And so they can be incredibly angry while simultaneously needing others to love them. And that can happen simultaneously because it is a dialectic. They're both true. Inappropriate, excessive, promiscuous attempts to get intimate contact. Please love me. Picking people who can't love them as mates, and then putting tremendous energy into codependency or getting the person to love them, which then gets them re-victimized. Impaired capacity to regulate empathetic arousal, lack of empathy for self. Now, it's interesting because sometimes they can get into being therapists or clergy and get compulsive into taking care of others, but they do this with self-hate. And so there's this inconsistency, which is if you can't care for yourself, you really can't care for others. And so we need to emphasize the intrapsychic work of being able to care for oneself as a requisite for being able to care for others. And impaired capacity to regulate empathetic arousal. Somehow, while looking like you're loving, so you have individuals who compulsively care for their children, but their children recognize that there's a genuine incapacity to love. And so we get confused about what love is. Feeding and watering your dog isn't necessarily loving your dog. And feeding and watering your children is not necessarily loving your children. And so, what is attachment security? I have this little thing I pull up, which is, I know you can't read it, but I'm going to read it to you. It just says 5 primary conditions for attachment security. Sense of felt security, a parent's consistent, reliable protection of the child from danger. 2, a sense of being seen and known, meaning promoted by the parent's consistent, reliable, and accurate attunement to the child. 3, the experience of felt comfort, meaning that you feel held, touched, consistent, reliable, soothing, a sense of being valued, that the parent is delighted with the child's existence, not based upon what they do, just because they are, and a sense of support for becoming one's unique best self, promoted by parents' consistent, reliable support of allowing the child to explore their environment and become who they are naturally. And so I think we poorly define what is adequate parenting, and when you begin to do that. And so one of the assignments we give our clients is to do a collage of what their childhood was. And then on the other side, what they want their childhood to be like. And so how they would parent their children versus how they were parenting. And oftentimes they look like night and day. And it helps them begin to recognize the deficits in caretaking and helps break down that loyalty to the family. Now, a lot of people get confused by saying, well, does that mean we're trying to get them angry at their parents? And the answer is no. We're not into blaming and getting angry at their parents. But sometimes there's a stage of breaking down the loyalty where they need to recognize that none of us have had 100% perfect parenting. And part of the job of an adult is to go back and look at their life and identify things that were optimal and things that were less than optimal, and understanding how that influenced their thinking, feeling, and behaving in the here and now. And so it's part of that process that we can begin to, and if I think about my parents, what I wish more than anything is that I could have had an experience with my parents where I could have been angry. Why did you do this? And they would have said, we made a mistake. I wish we knew now what we knew then. And the scariest thing is when parents say, I wouldn't do anything different. Because, as you become a parent, you make mistakes. And being able to recognize those mistakes and own them is so useful for a child's basically recovery. And so I love doing family therapy because I love working with the parents a little bit and helping them begin to own some of the things they did less than perfect and acknowledge it to the child and that there's some repair of that system. So family therapy is almost always involved with eating disorder. All right, now, I've said that this is a disorder of self. And so I now need to talk to you a little bit about seeding the development of the real self. And that there you begin to go back to Watkins and Watkins' work with ego states. It's in this one, it just says, if ego states are split off, projected, rejected, indulged, or otherwise unassimilated, they become black holes that absorb fear and create the defensive posture of the isolated self. Okay, so there's this concept, which is the addictive personality. Now, you see this a lot with binge eating disorder. With binge eating disorder, you have the person who they binge because when they eat, it's non-nutrition. They don't feel sated. It doesn't fill anything. And binge eating disorder is a disorder of love because the same relationship they have with food, they have with people. And so when they bond with their mother, they are unable to feel loved. When they bond with their wife or husband, they're unable to feel loved. And so no matter what they get, they need more. And so if you just deal with the food, you're missing the whole personality issue, which is they're binging on everything because it's everything they take in is non-nutrition. So love is non-nutritive. It's the same thing as we were talking about earlier. There's not a receptor inside to feel connected. And so what is that about, the addictive personality? It's always about ego states that are separate from one another, i.e. dissociation. And it's about structural dissociation, where parts of self have been disowned and rejected and unassimilated. And so the goal of repairing the disowned part of this, this lack of integration is having parts begin to talk to one another and integrate. And we're talking about this in the brain as well as psychologically. And so we're trying to identify the injured parts of self. So that gets us to the treatment model. So let me say the first thing about how I do treatment. The way I do treatment is I use the symptom as a window into the trauma. And so the client comes in and they're bulimic and they throw up, and they threw up last night. So it's pretty active, you know, so I have that ego state right in my office. So you threw up last night. Okay. So could I talk to the part that threw up last night? And can you find that part? Can you embody that part? If you could take a picture of that part, what might it look like? And now I'm bringing in kind of EMDR-ish kinds of stuff. In EMDR, you want to get a photograph of the injured aspect of what the person is talking about. If I could, what's in EMDR, you ask the question, what's the worst thing when you hate yourself? If you get a picture of the worst part of hating yourself, what would it look like? And so you want to begin to get a photograph or an embodiment of what the bulimic self might look like. Now, could you separate from that part? There's the Gestalt piece. How do you feel towards that part, Richard Schwartz would say. So you have now self with the bulimic part of self. How do you feel towards that part? Well, I'm appreciative of all that it does. Okay, can you tell it you're appreciative? So you form an internal relationship between the self and the bulimic part of self. And you begin to get them beginning to work collaboratively. And you as the therapist then facilitate an internal process internally. So the therapist is out here, the bulimic self is here. And so what Richard Schwartz says with internal family systems is we're going to do self-healing. And the therapist is a catalyst to self-healing. So self is going to say, ask that part, what's it afraid will happen if it stops throwing up? That is like $1 million question. And having asked that question now 1,000 times, the answer is almost always consistent. the bulimic self will say, I'm afraid we'll be alone. Okay? Now, if you listen to your client, I mean, that's just incredible because they're giving you the gift. They're telling you exactly what their problem is. That if you take away the bulimic self, they would feel alone. And feeling alone is like death. Nobody wants to feel alone. When you're that alone, you get depressed and you want to die. And so when you feel like you want to die, that's the most terrifying thing on earth. So feeling alone is terrifying, and you're trying to take the bulimic away from the person and sentence them to a life of aloneness. And so I don't want to try to rip bulimia away from the client until I understand its function and purpose, because I would then sentence the person to aloneness and potentially to suicide. So the purpose and the goal is not to take bulimia away, but to respect the bulimic self, understand its function and purpose, and help the person find a way to have connection without using bulimia. Okay? So the basic philosophy is a generalized one, which is when I treat addicts, I don't try to just take their addiction away through 12-step approaches or relapse prevention or cognitive behavioral therapy without yet understanding in a psychodynamic way the function that symptom served to them originally and how it's morphed and what function it's serving to them now. So now I've got that gift. The bulimic self says, I'm afraid of letting go. So the next question you ask is, if the individual could feel connected to others, would it need to continue to purge? And the bulimic self might say, yes. And you say, so what are you afraid will happen if you give up the bulimia and you're able to be connected with people? And it says, then we'll never be able to get back at mom. Oh, so bulimia is one way that you can get back at mom. Is that what you're saying? Yeah. Okay, now you've understand the second function of the symptom. All you had to do is ask. Now, when you treat dissociative disorders, there's a principle that Colin Ross emphasized in his original book, which was the dissociative client is just waiting for the right question to be asked. And here, if we get the bulimic self in your office, all you have to do is ask the question. If you just work on one thing, which is being isolated and alone, that's not going to reverse my bulimia because I need my bulimia to get back at mom. Well then, if there was a way of being angry at mom and telling her you're angry at her and addressing it directly, would you need to continue to purge? So you get to the second part of it. And there might even be a third. But usually there are 2 or 3 or 4 functions. And once you get them out, each of them needs to be dealt with separately. Angry at mom needs to be different than being isolated and alone. And so as you understand the functions of the bulimic self and you take those functions away, each of them increase your control over the bulimia. And each time you remove the function of the symptom, the self gets bigger. Because every time you integrate a part of self that's been disowned, then the self gets bigger and bigger and depression then becomes depleted. So remember that depression and anxiety are always underlying the eating disorder. I mean, if you look at the data is really clear that eating disorder clients have depression and anxiety before they have eating disorder symptoms. And so the depression and anxiety is always under that. And the depression and anxiety is oftentimes the result of having these lack of integrated dissociated parts of self. As these parts begin to integrate, the depression and anxiety remits in some way. So the therapy then involves helping the client reclaim parts of self, and the way to be able to do that is to follow the symptom. So let's pick another example. Let's say the client begins to restrict, and you've stopped them from binging, but now they're gone into dietary mode. You know, almost all of our clients, they go into over control and out of control. So they are anorexic one day, and they're binge eating the next day. And as you treat the anorexic, you have to treat the binge eating part. As you treat the binge eating part, you also have to treat the anorexic part. So these distinctions between the disorders is a bit bogus, because underneath the binge eater is the anorexic, and underneath the anorexic is the binger. And so we have to be able to treat both parts of self simultaneously. So that's one of the big mistakes that people make in treating that. And so as you begin to work with the binge eating part, now next you're going to have to begin to work with the part that restricts. And so as you bring the part that restricted last night in, you can begin to understand, what are you afraid would happen if you don't restrict? Well, I'm afraid I'll be out of control. What would be out of control look like? Well, I would be completely crazy, and I would not be able to control myself. I'd be highly impulsive, and I would do things that would be really destructive. So now what we have to understand is what the person's fears are of being out of control. And could you go back in time and find a time when you were out of control and what that looked like? And so there might have been a time when the person was, highly suicidal and out of control and wanted to die. And that by beginning to over control, it was the only thing that kept them from suiciding. And so the restrictive part might be, if I allow myself to eat, then I'm going to commit suicide. And so you have to understand, again, the trans logic and the function of where it began. I have to over control in order to feel safe. So you see what I'm saying is that the mistake of working with binge eating is not to work with the anorexic side. And the problem with the anorexic side is not to work with the part that's fearing being out of control. And these are different ego states. And so it's great. All right. So the other thing to remember is that there is a recovery part. And so these are the internal self-helpers in the dissociative framework. And I always like affect accelerated psychotherapy by Diana Fosha. And what I love about Diana Fosha in affect accelerated psychotherapy is that they are looking for the positives, and they notice the positives rather than the pathology. And so when you see a good affect accelerated therapist, they'll say something like, I noticed when we talked about that, there was a small smile in your face. And when you smile like that, the whole room lights up and is so bright. And I just love when that part of you is able to manifest itself. And so what happens is that you begin to give energy to the positive in some way. So much of therapy is oriented towards pathology that what we need to do as we increase self is mirror the things that are positive. If you remember that the most important part of attachment to me is that I love this number 4, a sense of being valued, promoted by parents, consistent, reliable, and clear, expressed delight in the child. And so my love of the client, my ability to connect the client, my caring of the client is a healing agent to bring the recovery part into the room. And I see what the client doesn't see. And so I'm a good enough mother because I'm continually mirroring. Now, the avoidant part of self, as soon as I do that, is scared shitless. And so everything you do has a counterbalance to it. And so if you're not careful to attune yourself to that, if you do that too soon, you can chase the client away and scare the shit out of them, because the avoidant part is saying, that nobody loves me and don't trust it. He's just doing that because he wants your money, and will then test you and test you and test you. And so attuning yourself to both parts. And so you're able to say to that avoidant part, that, when you hear that, what do you feel like? And, the avoidant part will say, I see you as dangerous. You're telling her lies. I hate you. I wish you would just go away. And you have to begin to get a therapeutic relationship with that part and be able to say, look, you have the same goals I have. You're there to help the client. So let me give you an example. One of the clients I'm seeing says, I've got a bad part. This part is dangerous and nasty. And, he's the bad one. And so I'm going to access the bad one, which is more of a persecutory part of self. And I'm able to say, I don't like that you called yourself the bad one. I don't think that's a good idea, because I think you've saved this person's life, many, many, many times. And I think it's wrong to call you the bad one. I would like for you to find another name for yourself. And we can collaborate on that. How about the one who deals with danger, or whatever it is that we want to rename? But I want the person not to hate that part of self, but to begin to understand its survival strategy. And so I'm going to blend the recovery part with the persecutory part. Now, what's the principle? When you're dealing with dissociative disorder, the first order of business is always to deal with the persecutory parts of self. And what we do is we call them failed protectors. They protected the individual once, but now they're endangering their survival. And so with the failed protectors, what we're trying to be able to do is turn their energy back to their original purpose and function, which is survival. And so we're trying to give them a different definition and a part. So what we're trying to do is take the persecutory parts and bring their energy into the recovery parts and help them become there's a lot of energy. So you never get rid of a part. That the bad part, the persecutory part, you're not trying to get rid of that part. You're trying to understand its function and purpose, how it's helped the individual survive, and then be able to work around the trauma so that that part can now take on a different function and purpose and use its energy for survival and become part of the recovery part. And as you're able to do that, you get more and more energy towards recovery in some way. So now the critical part can be pretty awesome. So I just had one client, write out a little bit about their critical part and try to get the voice of the critical part. And I think sometimes therapists underestimate the power of this critical part. Now, when you see this is one client. And if you try doing cognitive-based therapy, which we all do, and have them kind of address their negative beliefs, it's like they would say to you something like, you don't get it. Like every single thought I have is negative. And so I'd be just sitting there writing my negative thoughts all day long. And so what you want to be able to do is begin to look at how powerful this critical part is and how negative it is. And, you'll always be lonely. You'll never have sex. Nothing pays off, all this stuff. Well, there's, many, many pages of this stuff. I just sort of gave you an example. All right, now, we're working intrapsychically. We're working with parts being able to heal other parts. And we're working with integration of internal parts. But I never forget Kohut, because we also need others. And so what I love about the work that I do is I have a therapeutic community. We see 25 clients simultaneously. And we have groups. And in those groups, there is a lot of emphasis on getting feedback from others. So as we're doing these intrapsychic events, we're also facilitating interpsychic events. And we're increasing their social skills and their social interaction. And we have group activities where they have picnics and barbecues together. And we have non-eating disorder clients together with eating disorder clients. And we find that helpful because in the eating disorder clinics, we had competitiveness to who could be the most anorexic. And, they're being perfect means that you can be the perfect anorexic. And so when you have non-eating disorder clients, what we put chemical dependency clients in with eating disorder clients, it's so useful because so many of the eating disorder clients also have chemical dependency, and so many of the chemical dependency clients also have disordered eating. So as we put them together, they get to know each other and see each other and help each other. So the chemical dependency clients help the clients eat, and the eating disorder clients help the chemical dependency clients stay sober. And so I like mixing these together, and it makes an incredibly powerful therapeutic community and helps us deal with the comorbidity, because almost 80% of our clients have comorbidity. Okay, now I lay here out the structural deficits, and there I use the work that has been done by Stanley Greenspan in child psychiatry. And he has a book on structural-based psychotherapy. And what he says is that many people in our population have critical capacities such as self-observing abilities and difficulties with self-regulation and relating and communicating. Now, when I read all that, those words made sense to me. But since I've been working in this area, I've had to really think about this. I mean, I've looked at this for 20 years, and now I'm going to tell you a little bit more. Self-observing abilities. What does that mean? It means what we call now metacognition. And if you look at Bateman's work on metacognitive therapy for borderline patients, or some of the other work that's done on metacognition, which is really robust, what we're seeing is that the disorganized attachment client has a difficulty in knowing themselves, knowing the mind of self, and knowing the mind of others. Knowing the mind of self and knowing the mind of others. Now think about that. If you didn't know what you were thinking or feeling, if you were numb all the time and just thinking in an eating disordered way, then you couldn't trust yourself, because your feeling states allow you to be able to assess yourself and know when there's danger and know when there's not danger. And so since they don't have those internal signal states, they don't know the mind of self. And so knowing the mind of self is a goal of psychotherapy. If you can't know the mind of others, then how can you trust or feel safe with others? The people you pick are going to be dangerous. And so knowing the mind of self and knowing the mind of others is a specific deficit of disorganized attachment. And very specific intervention has to be done for each of those. Now, let's use something such as affective communicating. Affective communicating is an ability to express oneself. And so you can just hear in the way I'm communicating with you a lot of emotion and feeling. And if I'm numb and then everything is sort of, the world becomes bland in some ways. Being able to have differentiating experience, having boundaries, limits, becomes a really critical element. So as we've begun to understand how you treat dissociative clients, there's always a section for assertiveness. There's always a section on boundaries, and always a section on knowing feelings, and then using DBT to be able to use dialectical behavioral therapy for affect recognition, affect expression, affect distress tolerance, all those critical skills that Marsha Linehan outlines and has now, moved into such sophisticated channels. So, when people say they're cognitive behavioral therapies, behavioral therapies are critical. You can't do therapy without it. It's just necessary but not sufficient. And so most of us have had so many treatment failures that we've moved beyond cognitive behavioral therapies and enriched what we're doing by beginning to understand, the context of what we're talking about today. Anyway, a lot of these skills I incorporate into the life coaching piece of it, because it's hard to do all these things in your individual therapy. Most of my individual therapy is trauma-based. I'm working on being able to metabolize trauma, which is necessary before you can integrate dissociative parts of self. So I'm working in my individual therapy on dissociative parts of self and trauma a good bit of the time, and I rely on the groups to be able to do this. So that's why I'm fond of having my client do a piece of work in an intensive program like ours, where we're going to get 3 months of really dealing with all these deficits, and then getting the person ready for outpatient and convincing the insurance companies that it's worthy of doing this, because if you can do an intensive piece of work like this, the outpatient work is much, much better and much more highly successful. And so I'm fond of doing pieces of work intensively like this, and then doing outpatient work to follow it. And of course, that's really the goal of any inpatient program. The inpatient program is to have the person benefit from outpatient therapy. Okay, so now I'm going to move on to working with trauma bonding. Trauma bonding is that an eating disorder symptom is a reenactment. An eating disorder symptom is always trauma-based, and the symptom is the gift. The symptom is the door into the trauma. And so the way I work is I say, what is the symptom du jour? And I follow the symptom, and it'll take me back to the trauma. So I picked up this wonderful quote, which is, every deep desire, every powerful emotion gives a trail into the unconscious. Usually there's only one-way traffic outbound toward the world of sensation and action, but we can follow the trail to its source by going against the current. With this desire to go against desire, the bucks the demands of the biological conditioning, the journal of self-realization, being in earnest. Well, what I love about that is that for myself personally, when I feel really angry, my powerful anger is a door into my unconscious. Why am I feeling so much anger out of proportion to the situation? And my ability to go inside and struggle with that intense feeling is the way I do work on my own self-evolution. And so learning how to be able to move the mind of self and being able to look at your powerful reactions is your doing self-therapy. And so when the client comes in and has strong feelings, it's a door. So when the client comes in and says, you don't care about me, the client comes in and says, I'm really angry that, the client comes in and says, my boss is a jerk. All those are trails to the unconscious. And so if you listen really well, you frame that. Now, Joanna Fisher really says this so articulately. I love her. She says, you start with the assumption that every symptom is a valuable piece of data. You use psychoeducational material to make educated guesses about the meaning of the symptom, like being able to say, what is the purpose of your eating disorder, or have the persecutory part of self begin to listen to all the voices inside, and ask, how would this have helped you survive in an unsafe world? So the persecutory parts of self, how did it help you survive in an unsafe world? Look at what the symptom is still trying to accomplish, i.e. chronic suicidal feelings might offer comfort, a bailout plan. And once it's clear that the symptom is trying to accomplish, then the therapist and the patient can look at other ways to accomplish the same goal. I mean, can you get any more articulate than that? I mean, there's a cookbook. And, that's what she's best at. If you don't know Janina Fisher, it's like, boy, can she conceptualize. And if you're looking for, how to do it, you can read her book, and, it is just the most perfect cookbook of how to do this kind of therapy. All right. Now, I've used the concept of failed protectors from the dissociative literature. Where did the part get the idea that it had to coerce and shame you into dieting or restricting or binging as a way of survival? Perhaps a parent monitoring or scorning. Sometimes it isn't so subtle. You'll find that the mother put them on a diet when they were 7 years old, and you get pictures of what they look like at 7 years old, and there was no weight problem at all. And you realize that sometimes this is not so subtle. And sometimes the mother was constantly on a diet herself and over concerned with her appearance. So a lot of these origins of symptoms, have a real discrete kind of door. And, being that unconscious factor bringing into consciousness, is an essential basis of therapy. I mean, real psychotherapy is oriented into bringing unconscious material into consciousness. And unconscious is sometimes preconscious in the sense the person knows it, but it has not become explicit in their understanding of their reenactment and repetition and trauma bonding. So they're basically operating under the family rules. So in this case, I use Fossum and Mason's work called Facing Shame. And Fossum and Mason have these rules of shame-bound systems. And you follow the rules of your shame-bound system, which is that you find someone to blame. There's always someone at fault. Shame, you feel bad about anything you do that's less than perfect. And being able to blame everyone except for your family of origin. And other kinds of rules of shame-bound systems. Well, rules of shame-bound system maintain and perpetuate eating disorders. And so we have to coerce and shame the person into monitoring their behavior. And you must somehow be able to do that by being superior to other people. And what would make you more superior to other people than dieting? Because how many people are successful with diets? But the anorexic is able to do that. And so what I try to do is redefine anorexia, which is for other people, dieting is difficult. For you, eating is difficult. And so if you really want to be perfect, you need to be perfect in allowing yourself to eat. So there is spitting in the soup, to use an Adlerian term, and begin to get them the goal of doing things the hard way rather than the easy way, which is compatible with their system. And doing things the hard way is to eat. Doing things the easy way for them is to not eat. Okay, so then in order to be able to integrate, what causes dissociation is not only these events that occur in your life that don't fit into the full integration, but also traumatic experiences. A traumatic experience is, when you're a child, cannot be integrated. And therefore, in order to resolve trauma, one has to do the trauma work in order to be able to integrate the dissociative parts of self. And so what that looks like is the injured self might be that disgusting, dirty, filthy little girl, and we don't want to have anything to do with her. And that little girl is the one who refuses to eat. And so that is most common presentation. And so one aspect of this has to be a reparenting paradigm, where the self can come in and re-own the disowned parts of self and reparent them from age 5 to 7 to 9 to 11 to 13. And there has to be a commitment to self-care. And to do that, there has to be a real adoption. And so what we're going to do is a lot of work on reparenting and understanding what parenting is. And so, you know, there's a positive parenting book, which I'm really fond of. And in positive parenting, it teaches you how to begin to parent in a positive way, obviously. And I want them to positively parent their injured self. And I want you to be able to spend time each day connecting to that injured part of self and healing it in some ways. So self-healing, positive parenting is an essential component of that process. And it's not going to happen in a week. It's not going to happen in a month. It's seeding the development of positive parent and self-care that is a necessary component of recovery. And so what we're doing is we're blending the self energy and to beginning to work with these parts of self that have been disowned. And there's usually many of them. You know, there's that book called Life Without Ed. And although I'm very fond of that book and its author, the problem with that book is it somehow has this idea that the eating disorder self is a part of self. And so voice dialogue, people will oftentimes have people talk to your eating disorder itself. And the problem with that is that the eating disorder is embodied not in one part of self, but in many parts of self. So the angry part of self embodies parts of the eating disorder. The lonely part of self embodies part of this eating disorder. The sad part of self embodies part of the eating disorder. And so the eating disorder is not an eating disorder itself, but eating disorder cells. And so oftentimes I'll do what you do in dissociative disorders, which is I'll have all the parts of self come to the table. And we'll ask the client to bring all the eating disorder parts to one table. And we begin to acknowledge who's at the table and begin to have self work with each of those parts separately in some ways. And it's, again, all you have to do is ask the client, and they usually can do it for you and tell you which are the eating disorder parts and which parts you need to work with. And then you have to develop some order because they get jealous why you're working with that part rather than me. And we have to let them decide between themselves which is the parts to be able to work with. All right, now I want to talk to you about the recovery. And that recovery is different than treatment. And recovery is a commitment that a person makes lifelong. And so we're all recovering. And the therapist as well as the client are in recovering. And so we want to map out what is recovery. And recovery for the eating disorder client, takes an average of 7 years, even with treatment. And so we want to get them on the pathway of recovery and not look at it as, that slips and relapses are part of recovery. And slips and relapses are oftentimes a sign that there's another layer that we need to deal with. In EMDR, Francine Shapiro talks about that there are channels of trauma, and you clean out a channel. So I might deal with the sexual abuse or the rape, which is one channel of the trauma. Now I'm dealing a lot with people who have been in deployments. So, I have the first area is their deployment trauma. And then underneath that is the rape trauma. Then underneath that is oftentimes the child abuse trauma. And then underneath that is the attachment trauma. And so each of those are layers, and I have to clean out one layer. And the reason why people don't get better is because you're just dealing with the rape trauma, but you're not dealing with that which is underneath it. So when you have somebody who's coming with PTSD from deployments, that the reason they don't get better from the PTSD is that you have to clean out the PTSD channel from deployment, then deal with the rape trauma that's underneath that, and then deal with the channel of being abused as a child. And, a lot of them were depressed and suicidal before they went to deployment. And so there's just layers and layers and layers of stuff. So we have a TRICARE contract, and we're working, with soldiers in active duty. And they've received work from the VA, which is around the PTSD trauma, but they're not really dealing sufficiently with the complex trauma that's underneath it in some ways, and they're never going to recover because you have to be able to clean out those channels also. And, whether you do EMDR, internal family systems, somatic-based psychotherapy, affect-accelerated psychotherapy, all these are useful. I tend to use them all. That I've been trained in each of these. And so I'll do EMDR one day, I'll do internal family systems another day, I do exposure-based therapy a third day. And each of those tend to get to other pieces of the dissociated parts of self. So if you've been trained in one of these, get more training and get more training. I got trained by Francine Shapiro in EMDR for a week, and then I went back and did advanced EMDR training for another week. And I found that the new stuff is, much, much more profound even than the old stuff. So even if you've been trained in DBT, the new stuff is even much more profound than the old stuff. So you want to keep getting trained, and each time you get a training, it'll increase your competency in working with this. Now, in this, I just say taking the first step is important when you don't see the staircase. And my point is that if it's 7-year-old recovery, then you want to be able to look for the person to begin to identify treatment success, not as being cured from their eating disorder, because eating disorder cure is a recovery process, and they must understand what recovery looks like and look at the many components of recovery, not just in relation to the food, but in relation to other aspects of their behavior. So it's like going through a tunnel and you get to the other side of the tunnel, but when you're in the middle of the tunnel, you feel like you're never going to get there. And so you want to be able to understand that in some ways, that finally you get around the corner and you've reached where you want to be able to be. All right, so the eating disorder takes away your ability to be human, takes away your voice, takes away your ability to experience pleasure. And by recognizing that, teaching them how to play, teaching them how to laugh, teaching them how to have fun, teaching them to be, passionate. You're looking around my office, you can see my passion. I've got bright colors, I've got flowers, I've got aquariums, I've got a dog. I'm a passionate human being, and I'm a model to my client, and I want to awaken that all aspects of who they are and help them become who they were meant to be. I want to see the development of the real self by modeling. I want them to journal, and in their journal, I want them to write their worst eating disorder day and to read it to the group. And I want them to not go into minimization and denial. And I want them to begin to map out their feelings each day and articulate. And their eating disorder journal is something that we're going to look at every time they learn something. So at the end of a therapy session, I have them sit in the waiting room and write out what they learned in the therapy session today so they don't lose it. Because part of dissociation is amnesia, which is everything they learn, they dissociate it out. And one part of it goes, I'm not listening. And so you have to talk to the parts about what it is you're teaching and have them talk to the parts and be able to teach them what they learned today in their journal. So all parts have to read the journal. Then you have writing assignments somehow I always say it's not about the food, but it is about the food. And we have to destruct the meaning of the food. We have to sit with them during meals. We have to watch what their patterns are of avoiding. And we have to explore mindfulness and being in their body and allowing them to taste the food. So, the exposure part of this is an absolutely essential part. And, so eating disorder therapists are different than other psychotherapists in the sense that they're actively involved with exposures. Writing assignments. What is their phobia of fat? And letters to their eating disorder parts. How does the way you relate to food resemble how you relate to people in your journal? We have maybe 100 different assignments for eating disorder clients, and I have them all written out, and I could probably make them available to you if you're interested. But these homework assignments keep it all going, and a client doesn't leave the office without a homework assignment, because I want them to see therapy as something they do after they leave the session, not just in the session. And I want them to write in their journal, look in their journal. And so these are just examples of writing assignments to sort of remind you that it is about the food as well as about other things too. Now, in the research data, as you look at eating disorder patients who experience recovery, they emphasize these things. That one of the things that was really important in their recovery was a realistic appraisal of the medical dangers. So that really becomes important, that you understand the physiology and the medical aspects of eating disorder. What does it mean when you purge? I mean, I've had clients die from purging, and it's not benign. Improvement of the care of self. We talked about that already. New ways to self-soothe and regulate. So to understand the function of the symptom and know other ways of self-soothing. The ability to access social support from family, friends, and fellow patients. Enhance problem-solving skills, and improve capacity to invest in work and interpersonal relationships. So there it is. I mean, the clients lay it out for you. And so if you're trying to get goals of treatment, so that the person is mapping out their recovery, each of these needs to be a specific goal that you're actually helping the client do in between sessions. Now I'm mapping out what we actually do in treatment. And then responsibility for self is a principle they don't understand and needs to be taught and then practiced. Establishment of a true self, capacity to formulate goals, reclamation of one's personal power, decreased emphasis on perfectionism, firmer interpersonal boundaries, and cultivation of a sense of purpose and meaning in life. So this last one is spirituality. that we do have a specific group on spirituality. And it's, I'm very fond of Buddhist recovery, because in Buddhist recovery, they lay out, the Eightfold Principles. And in it, those become tools that people discipline themselves. And since the person does not have a sense of self, or they don't have a sense of what their life is about, and they don't have any goals of their existence, spiritually, they need to be more advanced than the rest of us. And they need to begin to have clarity in their recovery of not just recovering from food-related behaviors, but beginning to create a life worth living. And in that pace, the Buddhist principles are most useful in trying to be able to get the Eightfold Path of learning the tools to operate by. So what I say is that, in my life, I have implicit and explicit rules that I live by. For example, do unto others as I would do unto self. That I live by that principle. And the opposite of that, do unto self as I would do unto others. And so I want to treat myself with the kindness and compassion that I treat others. And compassion and empathy are the central points, the schema by which I operate from. It's the lens that I flow from. And so as I'm able to define those for myself, the mind of self, I can help the client begin to define what is their mind of self. And so I oftentimes say, what are the rules that you live by? Now, of all the therapies that I've found helpful, acceptance and commitment therapy is another form of therapy that I find really helpful. Because in acceptance and commitment therapy, there's an emphasis on defining your values. And when people are living within their values, oftentimes they're not depressed, they're happier. But people don't know their own values, and acceptance and commitments therapy help them be able to do this. So if you hope you get what I'm saying here, is that when I interview somebody for a job, I say, what kind of therapy do you do? And it's a trick question, because if they say, I'm a cognitive behavioral therapist, then I know that they probably haven't read anything since they left graduate school. But if they say, I do acceptance and commitment therapy, I do somatic-based therapy, I do trauma-based therapy, I do dialectical behavioral therapy, I do exposure therapy, then I want that person to work with me, because I know that they don't know. And that every skill that they get enhances and increases their capabilities. And so the lens is dissociation, the lens is self-development, the lens is being able to know the mind of self and others, and the lens is disorganized attachment. But all of our forms of psychotherapy help us be able to do that. Okay, now I'm going to turn now to the last part of this, which is that I was trained in the adult attachment interview by people who work with Mary Main. And it changed the way I think and the way I act. And there's another whole webinar on this, but I want to now apply this to eating disorder. And what Mary Main says is that we have to move people from disorganized attachment to what you call earn secure attachment. And so I had to operationalize what the hell that means. How do you turn somebody towards earn secure attachment? And so I wanted to spend maybe 5 minutes just talking to you about what is disorganized attachment and what is earn secure attachment. And then I'm going to talk about the principles of psychotherapy to do that. And I'm going to do that all in 10 minutes. Now, this is Mary Main, and what she does is she takes the transcript from the adult attachment interview, and she then, on the right side, begins to label these, and the left side this. And here we're going to look at content, and here we're going to look at process. And we're going to study each line and be able to study it in some way. Now, when you do that, it helps you be able to listen to your client with the lens of looking at attachment. And so what we're looking for are certain principles. What are these principles? Well, the first one is the content, which is, looking at the experiencer scale. And the experiencer scale, memories of special tender concern. I remember when my mom and I made cookies. Memories of doing something perceived bad by teachers. Memories of childhood fears, those kinds of things. So we're going to be looking at that in the interview. And what is love? And did the child get turned into an object? So it helps you listen to your client And I write down as they're writing various things that they say that will tell me something about their attachment patterns. And their speech patterns and the way they talk is a door into their attachment. Mary Main was a linguist, and she still is, and she takes the way people use language as a window into the way they think, neurolinguistic kind of programming. Two, that this is what to look at in your interview, which is the person avoids discussing relationships. That's avoidant attachment. Speaker recalls favorite towards siblings. Speaker derives self as favorite versus rejection from others. Parent is mad. Each of these are content variables that when they're in the interview, we lay them out as content for the disorganized attachment, making it clear that the child's presence is necessary maintenance for a sense of self, and so on down the line. And I don't have time to go through these now, obviously. I'm not going to read them to you, but look at them later, because these are the things you want to be particularly perceptive and aware of as you're doing your histories. And then the area of neglecting, the parent is inattentive, the parent is preoccupied with work, child remembers being crying at night. These are all part of it. So we're looking at loving scales and neglecting scales. Another scale that's really important is pressure to achieve scale. And this is like off the scale with regards to eating disorder clients. And it really brings up disorganized attachment, high ratings on success. And it's not necessarily what the parents even preach. Like I have one parent who goes down to Africa and helps people with AIDS. He's a physician. And the child thinks, how can I compete with my father? He's, a saint. And so why bother? And so her eating disorder is, why bother in some ways? And so if you have a Phi Beta Kappa parent, it's sometimes so overwhelming to a very sensitive child that they just refuse to even compete. And if you bring in the perfectionistic style that they're born with, why even bother? And so this pressure to achieve scale can be really the root of disorganized attachment, particularly for the eating disorder client. Okay, so then I'm asking you to look at the adult attachment interview and incorporate some of those questions into your histories, and that the answers to be able to listen to them. And you don't have to be able to score the adult attachment interview. You're able to instead just be able to be sensitive that these are all related to disorganized attachment. Dan Siegel does a beautiful job in his books of being able to emphasize that you don't have to score the adult attachment interview. It took me, 2 weeks of training to be able to score it. You just have to be able to study what it is that do an autopsy and look at the pieces of the adult attachment interview to know what to look for in your assessment devices and what needs to be changed in the recovery. So now, how do you do psychotherapy for distress? Well, you deconstruct the attachment. And so maybe this may be the most important slide. So I'm just going to take a breather here for a minute and say to you, I know I've overwhelmed you, but just stay with me. Just look at this slide for a minute. These are the components of disorganized attachment: idealization, loyalty to the family, dismissing derogation. My parents were good, then I went to college, and now I'm here depressed. It isn't important what happened to me. My parents did the best they could. Lack of memory. I don't remember the first 7 years of my life. Little articulation of hurt and distress. Positive wrap up. Well, my parents were never there, but they did the best they could. It made me a stronger person, made me more independent. These 11 criteria are the core of disorganized attachment. And so I do an attachment group each week, and in it, I deconstruct each of these pieces, help them see the components in their own lives, and then help challenge those things and help them understand that these contributed to how they think and feel and act, and that these need to be the change, because disorganized attachment passes itself down the generational line. And if you have disorganized attachment, there's probably about an 80% chance that your kids are going to have it. And so if you allow yourself to look at what it is that happened and begin to change it, you can save the next generation from that same distress. Since many of my clients have kids, that becomes a high motivator for the transformation of the eating disorder. Then the therapist job. The therapist job, obviously, is to see the development of the real self. And so your relationship with the client, the transference and the countertransference, is a door. And so I'm constantly watching what's happening in our relationship and being able to bring it out in certain ways. So I notice that you're getting later for the session. I notice that you're not really enthusiastic. I notice today that you're kind of depressed. I am constantly looking for what the person is saying and doing and feeling, and I'm present 100% in the session. I am attuned, and my ability to be with the client and be present and be attuned and be connected is part of moving them towards secure attachment. And the therapeutic relationship becomes critical in that. This is from David Wallen's book called Attachment and Psychotherapy, and it's a nice book. I think it's helpful. I don't think it's quite sufficient. Okay, so I finished, and I have 6 minutes left. Isn't that amazing? Aren't you impressed? So I can take some questions. All right, so Diana Fosha has a book which is called Basic on Affect Accelerated Psychotherapy. And I would Google her, and her book is awesome. And then she does trainings all over the country. And I've gone to her trainings, and they're just super. And it's beginning to notice the affect. She was trained by Davenlu. And if you know anything about Davenlu's stuff is magic. And she incorporates the Davenlu model into this, and it's really good stuff. Other questions?
Okay, Mark, you've got a question here. It says, can you say more about when a client has anorexia and also suffering from extreme forms of dissociation, DID? Can you please share more about the specific state of dissociation and treatment for this particular client once DID is identified, then accepted by the client?
Well, I agree with Richard Schwartz. I don't think working with DID clients is a whole lot different than working with non-DID clients. I'm always working with parts of self. The difference is that the amnesic barriers are greater with dissociative clients. And, when you have a satanic cult client or one of those types, there are these purgatory parts of self can be far more dangerous. So you have to really work with these purgatory parts of self first and begin to help them come into the real world. But then, there are some parts of self that want to kill the person. And, that becomes a little bit different type of psychotherapy. So I don't want to deal with that today, but I thought Kathy Steele does a really good job in her book of talking about how to deal with these kinds of purgatory parts. But since most therapists aren't dealing a lot with a severe DID, I'm not going to address that today.
Mark, can you elaborate on not pushing the concept of true self, how that might harm some client?
Well, I don't know what you mean by that. I mean, because I'm always pushing the concept of true self. There's a book called In Search of the Real Self by Masterson, and he lays out what is the real self. And all my psychotherapy is in helping the person move from false self to real self. And I want them to begin to have some image of what it is to be real self, and see the goals of psychotherapy towards getting away from being less reactive to what others think and feel and do, and beginning to know themselves and know who they are and what pleases them and what they want, and to be able to feel good about self-actualizing.
There's one here from Amanda. If the client is an adolescent and is in denial of the eating disorder and refuses to acknowledge that there's any underlying depression or anxiety, but yet their behavior is not reflective of this, how would you approach this if they are not ready to begin recovery but are only in therapy because of their parents?
Well, motivational interviewing is, the answer to that, which is that um, rarely does the eating disorder client come in saying, "Please fix me." You're getting huge amounts of resistance, and so you're always pulling out the carrot, and the carrot is being able to put the carrot in front of the horse, to be able to show them that you have something to offer them that will make their life better. And so I'm less invested in changing their food related behavior and more invested in helping them believe that I care about them and I want them to have a full life. And I'm going to begin wherever they need to begin and understand that they have avoidant attachment as well as preoccupy attachment. And so they're going to, for a while, hate me and hate coming into me. And, I'm just a vehicle to the parent. And therefore they're going to reject and abandon me. So, I have to attune myself to the avoidant attachment style and know that behind that is always the preoccupy, which is, I hate you, go away, please love me, please care about me. And understanding that there are the dialectical between that and slowly, surely beginning to weave my way into that process. And so, you have to have patience. And, eating disorder therapy is not for everybody. It really, there's special skill in being an eating disorder therapist. And that's why, in every community, there's usually, a handful of eating disorder therapists. And they are, have the patience of Job, because quite honestly, eating disorder may be the hardest problem to treat in all mental illness. What we find each decade is that there's a whole new reservoir of people who we haven't treated. And, it is true that there are more women presenting than men, but there's a lot of disordered eating in men too. But the brain of men is different than the brain of women. And these different systems in the brain seem to be more susceptible. So with men, we're seeing more sex addiction. And with women, we're seeing more eating disorder. But, we see it in both. And with sex addiction, it's not that different than eating disorder. There's a lot of overlap. I wrote a paper called, Treatment of Eating Disorder and Sex Addiction, pointing out the similarities and the differences. And each of them, you have to have special skills, but there's more of an overlap because the sexual addiction is more with men, eating disorder is more with women. And I think that's just because of the way the brain is, how it is. But if you think about it, eating disorder is primarily a transitional object. Food represents love. If my parents feed me, they must love me. And so the relationship between mother and daughter is a very complicated relationship. And since so much of the emphasis on women is on appearance and looking good, and mothers are being able to want their daughters to look good in order to be successful, obviously eating disorder is going to be more common among women than men. And the fact that men have not participated in child rearing means that there's a lot of father hunger. And so the father hunger from men being absent in the parenting paradigm also has a contributing factor to this.
Mark, can you speak about how you'd work with a client who has such strong dissociative parts that keeps them from being conscious of their experience? They keep responding, I don't know, to most exchanges. Where do you start? How do you proceed?
Well, I get the I don't know part to step back. There's what I call a blank part. And the blank part is the I don't know part. And so this part dissociates by keeping the person from knowing, keeping the person from feeling, keeping the person from sensing. That part is functional. So I get the blank or the I don't know part, and I work with that part and get it to step back and try to understand its function and purpose to keep the person safe. And, it's sometimes that simple, which is I want the blank part to step back and, or I want you to try to get to know the numb part. It's hard. I mean, that's one of the most common presentations, the I don't know part. And you have to understand it's a part.
Mark, any suggestions for a persecutory part that brings up old sexual trauma during nightmares?
Yeah. You have to work with those parts. And what I do is I try to spit in the soup. And what I mean by that is that um, I say to that part, tell me how you came into being. And the part will say, she was being raped and horrible things were done. And we go through the details of it. And I say, so you helped her during that part survive. Is that what you're saying? And, you're incredible the way you saved her life. And what I don't understand is how you move from wanting to help her in that way to wanting to hurt her. Because now every time you present that image while she's sleeping, she is re-traumatized. And how would you hurt somebody you care so much about? And then the person will start crying and they'll say, I can't stop it. And I will say, okay, let's begin to get some tools to help you stop it. So I want to look at the original function and remind the part what it's, because these are failed protectors, meaning they once protected, but now they're not. And you want to show them how they turned in from a real protector to a failed protector and give them the job of really protecting them. So your new job is helping them sleep at night. And how are we going to be able to do that? And, in working with a dissociative client, there's a general rule, which is if you don't know what to do, ask the client. So you can say, does any part inside know how we can help the client sleep without having nightmares? And usually they'll tell you.
Mark, how would you apply some of these principles with teenage, age 13 to 16, who have AFRID?
I don't know. With teenagers, they're a little bit more rebellious, but the work tends to be a little bit easier because it's less, it morphs over time. So by the time they're 30 or 40, there's a lot more trauma and a lot more functions of the symptom. So the parts are a little bit more discrete and you can work with them more easily. So the teenage self, that's an age where the self is still developing. The principal part of adolescence is the development of the real self. And so you're using that adolescence as a time to begin to shape the vicissitudes of the diamond of the parts of self and who they are. And so you're using positives to help them find some definition of self that will potentiate their growth and development. But I want to thank you all for attending, and I'm really appreciative, and we're going to do this every other month, and we'll come up with some interesting topic and let you know. But thank you for attending, and anyway, thank you all for coming, much appreciative. Feel free to write or call if you like, if you have specific questions. Bye-bye.